Waalaikumsalam warahmatullahi wabarakatuh.
Can you hear me?
Hello, Doctor. Yes, we can.
Hope
Can
inshallah
you hear
all
me,
of
Doctor?
you are okay. Yes,
Alright,
yes.
okay.
How many candidates now attending?
Right now, including you, is 9.
How
But
much is our group? How
we
many
should
candidates
have
for the group?
10. We should have 10, including you.
Okay, how
Oh,
many now?
wait.
Yes, how many now present? I think you still lagging it for your.
Yeah. 1, 2, 3, 4, 5, 6, 7, 8, 9. Two more, two more person.
So we have someone contacted after 10 minutes, unless they have something urgent, we will consider them absent.
Right.
Okay.
Should we wait them or how, Doctor?
No, you them that we are giving them a short time to join us, please.
Okay. Right.
Okay. Let's go for the الكتاب.
Afiq, you can present.
Can we start with the first group, please?
Yes, Doctor.
Okay.
Can you guys see the slide?
Please, everyone, try to mute his microphone. Yes, we can see.
Okay. Bismillahirrahmanirrahim. My name is Muhammad Afiq bin Azmi, and I will be presenting about the case presentation on renal system with my group mates, Nur Shazwani. So these are our table of contents. We will be having a history taking and also the role play. And then for physical examination and diagnosis and discussion, I will be presenting. For investigation, management, and prognosis, my group member will be presenting, and finally we'll be having asking questions. Okay. For history taking, I will start with our role play. I will be acting as a medical students, and Shazwani will be acting as a patient's mother. Okay. I will start first. Assalamualaikum, Madam. I am Afiq, a third year medical student in pediatric posting. I am in charge of assisting you today.
Waalaikumsalam.
Okay. Is this your child? How old is he?
Yes, this is my child. His name is Adam, and he's 7 years old now.
Okay. What brings you here today?
So I've noticed my child developed facial swellings 5 days ago, and later I realized that his domain was distended. But 3 days prior, he also experiences loose stool, and he vomit. So this is really worried me.
Or how did you realize that he had facial swelling?
So I realized that the area around his
Uh, does does your son experience these symptoms before?
So actually, this is not the first time that my son experienced this symptom. So before he was admitted due to the symptoms, and he was diagnosed with nephrotic syndrome back in 2016. And so we currently still under follow up in klinik kesihatan. And as I remember that there were also 3 time relapse of this disease in the past years. And I also done the urine dipstick test, which been by the and the result for the dipstick is +4 of protein today, and for today's it is +3 of protein.
Okay. So let me clarify. Your son has a nephrotic syndrome, right? Back in 2016, and other follow up in klinik kesihatan, right?
Yes, true.
So he comes here due to facial swelling, right?
Yes, and I worry
Okay.
about the loose stool and the vomiting.
Okay. So does your son has any other medical illness before?
And that I was aware of.
Okay. Is there any food allergy or any allergic to any medication? Okay. So how many times does he vomit and when did it start?
So the vomit started 3 days ago. So it occurred when I realized that he was unwell. So he vomit about 10 times that day.
Okay. Can you remember about the contents of the vomit?
As far as what I remember, he vomited out some minimal fluid content, but there is no food content in the vomit.
Okay. So what color was it? Does it green or yellow?
So it was yellowish in color.
Did you see any blood in it?
No, I do not see any blood in the vomit.
So is there any other symptoms beside vomiting and facial swelling?
Um, I just remember that 2 days ago he had a cough and fever.
Oh, how did you realize that he had a fever?
So when I touched he was warm upon touch
Okay, so
for
two
him.
days ago, did you give her anything to reduce the fever?
I gave him paracetamol and the fever temporarily. But the next day he suddenly experienced rapid breathing. So I don't know why.
Oh, okay. May I ask, do you live in a dengue or malaria prone area?
No.
What was the characteristic of the cough?
So I would say that he would complain to me that it would like kind of chesty in nature cough.
Uh, Does it have any sputum associated with the cough?
When he cough, he also release a green sputum.
Okay. So does the cough associated with any sounds or breathing problem? Mhm.
Know that I know.
Okay. Does he take medication for the cough?
He did take a medication for the cough, but the cough did not resolve.
Okay. Does any of the family members experience the same symptom?
So, I think no, his father caught a flu before. So
Oh,
he
his
did not
father.
do that.
Do you travel lately?
No, because of the
No.
pandemic, we do not travel.
So About his bowel habit, can you describe a little bit about his bowel habit?
So, he said that 3 days ago he experienced the loose stool, but he also complained to me that he have the stomach pain, abdominal pain, and distension
Or
when
are
I
there
checked.
any blood in the feces?
No, there is no blood in the feces that
No
he
blood.
reported to me.
How many times does he defecate?
Uh, so the loose stool occurs 5 to 10 times daily.
5 to 10 times, eh? Okay. For the urination, do you see any abnormality in his urination?
I noticed, and my child also told me that he peed less frequently during these past few days.
Is there any association of pain?
No, there is no pain during the urination.
Okay. Do you see any blood in his urine?
No, I did not see any blood.
Does the urine is tea colored?
No, it's just a clear colored urine.
Clear colored. Uh, for the abdominal distension, may I know when did you realize that your son has abdominal distension?
When he wake up in the morning, he complained to me that there is a throbbing pain at his stomach, his abdomen. So when I tried to examine the abdomen, I found that it is distended.
Okay. Do you know, does he experience any itchiness or redness over the distended area? No. Next, did your child complain of any night sweats?
No,
No. Are there any joint pain also? Is he complaining about joint pain?
there is also no joint pain.
No joint pain. How about muscle pain?
No, he did not complain any muscle pain.
Does he often get bruises? Like he easily bleed like a nosebleed?
No,
No.
he just
And next, any
bruises.
discoloration of the skin? Like are there any rashes on the skin?
No, that I not. No, I know
Okay.
that.
During his birth, are there any complications during his birth?
So he had a normal birth, and there wasn't any complications.
How many siblings does he have?
So he is the whole oldest one, and he has one younger sister.
Okay. Do you and your husband have any medical conditions?
So as for me, I have no any medical condition, but my husband, he has hypertension and also bronchial asthma.
Okay. May I ask what are your occupations? You and your husband?
So I'm a businesswoman, and my husband is also he is a businessman.
Okay. May I ask if either any of you smoke?
So for me, I do not smoke, but my husband he does smoke.
Okay, does smoke. Um, does your child follow the immunization program?
Yes, we do. We do bring our child to the clinic for immunization program. So it up to the schedule with his age.
Okay, so was he breastfed during his child?
Yes, he was breastfed up to 7 months. Then I continue with the formula milk, and he started weaning at 6 months old.
Okay. Can he do daily routines on his own, or does he need your help?
Yes, he can. He can do his daily routine. So at home, he managed to do the self-care activities like eating, bathing, and wearing clothes all on his own.
Mm. Does he go to school? And how was his performance at school?
Yes, he does go to school. He go to school. So he is very smart, active, and he has lots of friends. He makes well with his friends.
Are there anything else that you like to mention?
I think that it's all that I would like to mention.
Okay, thank you for your time, madam. Later, I would like to do a physical examination on Adam to know more details about his condition. Okay, that's all for our role play. So I will be summarizing first about the chief complaint. The patient is Muhammad Adam Afiq, a 7 year, 5 months old Malay boy admitted to HTAA due to periorbital edema, facial swelling for 5 days, loose stool and vomiting for 3 days duration. For the history of presenting illness, uh, the day one of the illness is 10 days prior to the admission. So from the history taking, the intermittent chesty cough is present on day one of the illness, and the productive cough is associated
Please,
with.
you need to summarize, not to repeat everything.
Okay, okay. For the positive finding, um, on the day one, he has intermittent chest pain, intermittent chest cough with productive sputum and green. And then for the history of there are positive history of sick contact at home with his parents. And next is for the day five, he experienced facial swelling, periorbital edema, and then it progressed to generalized body swelling. For the first, the swelling start from the right side of the face around the eye, followed by the left side, and then there is a positive pedal edema noted up to the shin. The stomach is also enlarged than usual, and there is enlargement of the scrotum. For the day seven, the patient had loose stool, vomiting, and also generalized abdominal pain and distension. Uh, he also vomit around 10 times a day with minimal amount of fluid, with yellowish in color, no blood or mucus. And also loose stool, they are 5 to 10 times per day. He had a poor oral intake due to reduced appetite due to vomiting and diarrhea, and then there is oliguria with no hematuria and no other significance. 2 days prior to the admission, the child start having the fever. The mother tried to relieve the patient's fever by giving paracetamol. And the next day, the patient experienced rapid breathing associated with the chest indrawing and uh, noisy breathing. And for the endemic area, they does not live in dengue or malaria prone area. And then for the history, I will be summarizing. The positive one is for the past medical history. The patient has multiple admissions due to frequent relapse of steroid-sensitive nephrotic syndrome. In 2017, he had 3 times relapse in February, April, and August, and then no history of other medical illnesses. For the drug history, the patient is prescribed tablet steroid, which is the prednisolone, every day and was tapering down. And he also had omeprazole, ranitidine, penicillin, and hydrochlorothiazide, and also furosemide. For the birth history, there are no event. It is uneventful. Immunization history, the patient took vaccination up to his age according to the immunization schedule by Ministry of Health Malaysia. For the growth and development, the patient is has a normal stage of academic performance, but he unable to participate in sport due to his illness. And then nutritional history, he took nutritional food every day, uh, and he is not a picky eater. For the family history, the patient is a first child out of two siblings. The father is a smoker and also had medical conditions such as hypertension and also bronchial asthma. For the social history, he lives in a single-story terrace with complete basic amenities, and he has currently treated at klinik kesihatan Kurnia with 10 minutes of driving distance. And next, I will be summarizing about the physical examination. For the general, the patient appear conscious, alert, and sitting upright comfortably. And there is facial puffiness noted. And there is also presence of granula attached on the dorsum of the left hand with no active infusion. For the face and neck, the facial swelling is present but is not tender or red. And then there is presence of pedal edema up to mid-shin. For the peripheral, the the BCG scar is noted on the left deltoid. And then anthropometric measurements, for the weight, the patient is around 24.4 kilogram. The height is 120.5 cm, and the BMI, the patient is underweight. For the vital signs, his temperature is 38.1, which is febrile, and then the blood pressure is 128 over 95, hypertensive, and other is not significant except the pain score the patient has is 5 over 10. Okay. Next, for systemic examination, for abdomen, the abdomen distended and move with respiration. And the on palpation, the abdomen was soft and non-tender, no mass felt, no hepatomegaly or splenomegaly. The kidney is not palatable, and on percussion, there is positive shifting dullness and fluid trail, which indicative of abdominal ascites. And then for auscultation, there is increased bowel sounds with no bruit. For the cardiovascular system, there are no significant in cardiovascular system, as the both first and second heart sounds were heard. For the respiratory, uh, there are no significance also, uh, except that he has cough. And then for the neurological, also non-significance. And then we proceed with the diagnosis. The provisional diagnosis that is given is the hypovolemic state with underlying frequent relapse steroid sensitive nephrotic syndrome. The points for this provisional diagnosis is the patient has underlying nephrotic syndrome. The patient has also generalized body edema, massive proteinuria, reduced urine output, and also generalized abdominal pain. And the points against is there is no cushingoid features on the patient. For the differential diagnosis, the first one is post-streptococcal acute glomerulonephritis. The point suggest is edema, oliguria, proteinuria, and hypertension. But the points again also is no gross hematuria. The second for differential diagnosis is SLE, systemic lupus nephritis. The point suggest is generalized and frothy urine. There are no myalgia, arthralgia, mouth ulcer, skin rash, fever, and photophobia. No family history of autoimmune disease. Other is the third one is allergy. The points for is edema, but there are no rash, pruritus, no personal or family history of disease, and no non-food allergy or medication. Fourth one is protein malnutrition. Edema, ascites, poor oral intake are the points for, but there are no muscle wasting, no skin changes, no loss of appetite, and no brittle hair. For the fluid overload secondary to heart failure, the points for is leak edema and also ascites, but there are no heart failure symptoms such as orthopnea, paroxysmal nocturnal dyspnea, shortness of breath. There are no cardiomegaly, the apex beat not shifted, and there are also no hepatomegaly. And the last one is chronic kidney disease. Uh, the points for is generalized edema and oliguria and no previous history of kidney disease. Next is for discussions.
You will do all alone?
No. My friends will be after this.
So if you come back to your differential diagnosis, please. Post-streptococcal glomerulonephritis, you mean here secondary nephrotic syndrome, not primary, by systemic lupus.
Yes, secondary.
What other causes which can cause secondary nephrotic syndrome?
I think I have the slide after this in discussions.
I need the knowledge in the brain before slides.
Okay.
I'm just examining you to give you marks.
Okay.
So any cases effects that can cause secondary, you must include in the history.
Yes, secondary nephrotic syndrome.
Yes.
The examples such as like allergic reactions, diabetes, amyloidosis, and also malignancies.
Yes, but also infection are very important. Some
Yes, infections.
hepatitis are very important.
Okay.
During your taking the history, you didn't ask your patient any details about the course of nephrotic syndrome, when she got it, what is the current indication, how much is the dose? Is it important or not?
Yes, important.
Why you missed that?
For secondary nephrotic syndrome,
No, not for secondary, for your patient. During getting the history, you didn't touch any detail. You just accepted the diagnosis of nephrotic syndrome, but you didn't ask about the course of the nephrotic when diagnosed and what is the current medication the patient are getting and what is the knowledge of the mother. You didn't touch that, which is not enough during taking a history. Even the patient is coming for me now for a certain problem, I mustn't miss these details, please. Okay?
okay.
So for any patient with chronic disease, during taking history, it is very important. Even if the time is limited, you must assign a short time to go through the course of the disease. When it started, how many times of admission, how many times of relapse, what is the current medication? Does the patient experienced any other investigation which we need to comment? Okay, especially renal biopsy. If the patient has frequent relapse or patient steroid steroid resistant or dependent or like that. So you must know also the indication for renal biopsy, and you must ask specified for that, done or not. Okay,
Okay,
this is
doctor.
this is number one, which is very very important. The other thing about the vomiting 10 times is not very simple. As you know, the patient of nephrotic syndrome has edema, which means he has a lot of extra fluid, but at the same time, there is constriction of the intravascular fluid. So the patient easily can get hypotension. So you must comment about your presentation about the vital signs, the blood pressure, and always remember that vital signs are very vital. Okay.
Okay.
You asked him about the vomiting and its color. It's good, but also you accepted the issue of coughing a green sputum. Is it normal to have a green sputum?
No.
Okay, and you didn't ask with that for how long and it came before, or this is the first time, because green sputum usually we suspect it can be infection. And this patient of nephrotic syndrome, okay, is liable for infection. You know that. So you must also ask about this one. Chest pain. I know that we are just starting for our year 3, but chest pain are very important. If the patient tell you I have a chest pain and you examine his muscles and you find it looks like myositis or osteochondritis or whatever, because we need to rule another causes. At that situation, you must comment on the heart specifically, okay, and the chest, of course, examination. You must give attention to some important points during our history, okay?
Okay.
So, in spite his edematous, you must also comment about he has any signs of dehydration or hypotension or intravascular collapse. You must be able to ask yourself why this patient has chest pain. Maybe he got some pleural effusion, he got even pericardial effusion, he got infection. It is very important for this patient, as I told you, each case has its own uh, complication. Okay, Afi? So it's very important. What if the investigation, if you see this patient in the first time, what investigations you are going to consider?
Hydration status.
I mean, you just seen your patient on 2017, the first time he got swollen. Okay, so what investigation you are going to consider at that time?
Mm. For the edema,
Yes, the patient presented with you with edema and maybe oliguria. So what?
I think renal profile,
Okay, what else?
and then the urine analysis,
Looking for what?
if there is a presence of protein such as amyloidosis,
Mhm.
also can be due to systemic lupus nephritis for renal biopsy.
So can you tell me what is the criteria for diagnosing nephrotic syndrome? Usually we have four criteria.
Is it a massive proteinuria,
Okay,
hypoalbuminemia,
okay,
uh, hypotension,
no,
uh,
complication. You said there is massive proteinuria, which
uh,
can cause it. What else?
We can cause hypoalbuminemia.
Okay, hypoalbuminemia is number three. Good. What is the remaining one?
Mm, hyperlipidemia.
Yes, this is a very important because it is one of the causes of complication. This patient can get thrombosis and thromboembolism. It is very important to ask for that and to ask investigations for that. Okay, this is a very, very important point. Okay, so you must know what investigation is required and what is the benefit because you are not doing investigation just to do investigation. If I did some investigation, I didn't go through it, what is the benefit? It is wasting of resources. And I must need to know how to make best use of the investigation in my hand. Okay. Nur Shazwani,
Yes.
can you tell me most common complication of nephrotic syndrome?
Uh, Hypovolemia. Hypo.
Okay. So hypovolemia can cause what? Hypovolemic shock.
Hypovolemic shock. Yes.
Okay. What else?
Thrombosis. Thromboembolism.
Yes, secondary to hyperlipidemia. Very good. What else?
Um,
We just speak about
Accurate infection, because patient with nephrotic syndrome is prone to the infection.
yes. We must know why the patient is a direct question which must be clear. Why this patient has susceptibility of infection? What type of common infection he can practice? Okay, and which microorganism also can do that. This is very important. Okay. So the issue now is our job is try to build up our thinking inventory for the knowledge. Okay. I asked Vic about it the first time, so you must go for all differential diagnosis. Is it nephritic? Is it nephrotic? Is it chronic renal disease? But there is many organ also can cause edema, which is the
Cardiac.
cardiac. Yes. What else? Hmm. Who can answer?
Liver.
Liver. Yes. What else? So this is our point now, how we are thinking with practicing medicine. Okay. Usually we have like initial impression and we need to either improve or rule out like that, but we must know the other. That's why sometimes we need to ask many investigations or like that just to rule out. Okay, let's go now for the your slide presentation and we'll finalize after them.
Next for discussions, I will be presenting about the difference between nephritic and nephrotic syndrome. As the latest is nephritic is I, so we can think of inflammation, which is the inflammation of the glomeruli. For the nephrotic, for the O, we can remember the hypoalbuminemia or also edema. Uh, for the presentation, the edema is usually in nephrotic syndrome, but it is less likely in nephritic because in nephritic we can see the presence of hematuria, while the nephrotic less likely to have hematuria. For details about the nephrotic syndrome, is a condition involve the loss of significant volumes of protein via kidneys, which is the proteinuria, which results in hypoalbuminemia, and this also leads to hyperlipidemia. The, the definition is both massive proteinuria with hypoalbuminemia and also hyperlipidemia. It can be caused by primary or secondary in the next slide. Usually in adults, it is caused by diabetes mellitus, amyloidosis, SLE, and also focal segmental glomerulonecrosis. For the children, the most common cause is minimal change disease, and the edema of nephrotic syndrome decrease the amount of intravascular fluid and decrease the blood pressure, which stimulate the kidneys to release the renin, and ultimately this activate the renin angiotensin aldosterone system, which adrenal glands will respond by release aldosterone to retain more sodium and water, which leads to more edematous condition for the patient. For the laboratory findings, we might find hypoalbuminemia with passive proteinuria, hyperlipidemia, and also waxy cast and oval fat bodies in the urine. These are the causes of the nephrotic syndrome. The primary or idiopathic nephrotic syndrome, such as minimal change nephrotic syndrome, primary focal glomerulosclerosis, membranoproliferative glomerulonephritis, and also idiopathic membranous nephropathy. For the secondary nephrotic syndrome, it is due to underlying conditions such as systemic lupus erythematosus, and then the Hinox Schönlein purpura, Wagner and other vasculitis, and then chronic infections such as hepatitis B, hepatitis C, malaria, human immunodeficiency virus. It can also due to congestive heart failure and also constrictive pericarditis, allergic reactions, malignancies, diabetes, amyloidosis, and also the renal vein thrombosis. For the signs and symptoms, uh, as a result of hypoalbuminemia, the nephrotic syndrome is associated with edema due to reduced oncotic pressure, and then hyperlipidemia and hypercoagulability. The symptoms is peripheral edema, which is more common in adults, while as for the children, facial edema is more common. There is also can be frothiness of urine, fatigue, poor appetite, recurrent infections due to immune dysfunction, venous or arterial thrombosis, such as myocardial infarction, deep vein thrombosis due to hypercoagulability. For the signs, we can see the edema, especially in periorbital, lower limb, and also ascites. There is also presence of xanthelasma, also called xanthoma, leukonychia, and also shortness of breath, with associated with chest signs of pleural effusion, such as stony dullness in the lung bases. These are the common complications for the nephrotic syndrome. The first one is blood clots due to the blood proteins is also diffuse up during the urination. This increase the developing of the blood clot. Next is high blood cholesterol and also elevated blood triglyceride, because the liver try to compensate the low oncotic pressure by producing more lipoprotein. And then poor nutrition due to loss of too much blood protein can result in malnutrition. And then high blood pressure due to excess body build fluid can raise the blood pressure. And then acute kidney injury due to damage to the glomeruli, and also the waste products can build up quickly in the blood. Uh, this needs emergency dialysis. For the and then chronic kidney disease, it, nephrotic syndrome can cause kidneys to lose their function over time, and this leads to uh, end-stage renal failure. And last one is infections because it has associated with higher risk of infections. Next one, Shazwani will be presenting about the investigation, management, and also prognosis.
Okay, I will continue on the investigation first. Okay, next slide. So investigation that can be done in diagnosing nephrotic syndrome is we can first to do full blood count. So we check for the components of the blood such as the hemoglobin, the what blood cell, hematocrit, and others. So we want to look for evidence of anemia or infection. So next for the renal profile, so it is used to investigate the function of kidney, and we also need to do to assess and if there is any complication of the nephrotic syndrome, and we need to check for the urea, electrolyte, and the creatinine level. So the serum creatinine value usually normal, but it may be abnormally elevated if there is diminished renal perfusion from the contraction of the intravascular volume. Next, for the liver function test, so we check particularly for the serum albumin because in nephrotic syndrome patient they have a hypoalbuminemia, so the serum albumin level is will be lower than 2.5 uh, gram per liter. Next, for serum cholesterol, we check for the hyperlipidemia, uh, which is the characteristic of nephrotic syndrome. And then urinalysis, so we can so in urinalysis we can see the foamy or frothy urine, and also we can check the presence of the protein. So in a patient with nephrotic syndrome, it will reveal 3 plus or 4 plus proteinuria. Next is quantitative urinary protein excretion. So we assess the spot urine protein creatinine ratio or the 24-hour urine protein. So in nephrotic range proteinuria, the urine protein creatinine ratio value is more than 2. So it will indicate the nephrotic range of proteinuria. So the other investigation we use to evaluate to rule out the secondary form of the nephrotic syndrome. We suspect in children more than 10 years old. So we you do the anti-nuclear factor or anti-double-stranded DNA, systemic lupus erythematosus, and the serum complement C3 C4 level. So the serum complement C3 C4 level usually in post-infectious glomerulonephritis it will be low. The serum the C3. Next is the streptolysin or titer to exclude the post-streptococcus glomerulonephritis if we suspect this instead of the nephrotic syndrome. Next slide. Okay, for the management. So after the patient have known to have uh, nephrotic syndrome, and we already exclude any other secondary causes. So the patient usually have the idiopathic nephrotic syndrome. So the general management. So a normal protein diet with adequate calories is recommended in this patient. And usually when the child has edema, no added salt to the diet. And penicillin is recommended at diagnosis and during the relapse of this disease, particularly if there is a presence of gross edema. But the dose of the penicillin, it depends on the age of the child. Next, need to do the careful assessment of the high hemodynamic status. So we look for the sign and symptoms of the hypovolemia and hypovolemia. So in managing a patient with nephrotic syndrome, fluid restriction usually not recommended except if the patient is in chronic edematous states. So diuretic such as furosemide, it is not necessary in steroid-responsive nephrotic syndrome, but if we want to use the diuretic, we should use with caution because the diuretics, the furosemide, it can precipitate hypovolemia. So the albumin can be used in symptomatic grossly edematous states together with the intravenous furosemide to produce diuresis. But fluid overload and pulmonary edema can occur with albumin infusion, especially in those with impaired renal function. So the urine output and the blood pressure should be closely monitored. So this next for the general advice in managing the um, patient with nephrotic syndrome. So first, we need to counsel the patient and the parents about the disease, particularly with regard to the high probability of relapse, which is 95 to 85% of case of child will have relapse. So next, the child parents may be taught on how to use a dipstick and interpret the result to monitor the degree of proteinuria. So it should be once daily dipstick testing of the first morning urine spot. And the patient advised to consult the doctor if there is a albuminuria equal or more than 2 plus for 3 consecutive days or 7 days. And if the child become edema regardless of the urine dipstick result. So next, if the children are on a systemic corticosteroid or other immunosuppressive agents, so we should advise the children and the parents to be cautioned about contact with chickenpox and measles. And if they are exposed to this disease, if they're exposed with the person with this disease, they should be treated like any immunocompromised child who has come into contact with this disease. So they should be treated like the immunocompromised child. Next, for the immunization in a child with nephrotic syndrome is if the child is on corticosteroid treatment and within 6 weeks after cessation of the treatment, so only kill vaccine may safely be administered to the child. So for live vaccine, it can be given 6 weeks after the cessation of corticosteroid therapy. And pneumococcal vaccine, it should be administered to all children with nephrotic syndrome. If possible, give the vaccine when the child is in remission. So this is to lower the risk of serious infection. Next. Okay, so this is how do we manage the complication of the nephrotic syndrome. So the first one, the hypovolemia. So we can see the features of hypovolemia, such as the abdominal pain, cold peripheries, poor pulse volume, hypotension, and hemoconcentration. So you can infuse the albumin at zero point 0.5 to zero point 0.1 per kg per dose fast. But if the albumin is not available, we can use other volume expanders, such as human plasma. But in this patient with hypovolemia, do not give the furosemide because it can worsen the hypovolemia. Next is primary peritonitis.
Shazwani,
Yes.
yeah, Shazwani, just go for the general line of treatment because as year three, you need to concentrate in the initial, okay? Just go for the general lines. It is
Treatment.
a good connection. Okay, yeah, general lines. Okay.
So I skip this slide. I move to the treatment.
The most important primary peritonitis, okay, and thrombosis, dyslipidemia, edema. Okay, come for the next one.
This is just the term and the term for the treatment of the nephrotic syndrome, the steroid resistant, steroid dependent.
Yeah, it is very nice slides. Did you write your reference for this or not?
Oh, I did. We did not put the reference, but I got this from the UM pediatrics book, textbook of
Even
textbook
even
of
if you
pediatric and child health.
find anything, you try to have the references. You must write it at the end.
Okay, doctor.
Of course, our pediatric protocol must be included. So this is a very important. What is the remission, relapse, what is the steroid sensitive, what's steroid dependent, and all this. Okay, good. What else?
The corticosteroid therapy, which is the mainstay of the treatment.
Yes.
Okay.
So all of you need to read that. Okay, next. I just need the time, some skills, better than some knowledge you can read, inshallah. The follow,
I'm
I,
sorry, doctor. I cannot hear you. I don't hear you clearly.
next slide. Where are you, Shazwani?
Yes, doctor.
The next slide.
Next slide. Because the your voice is lagging and I cannot hear it well.
Okay, I am here inside the Kulleya. Maybe the internet is now. Next, yes. This is also we must know generally if steroid not enough, what we can use. We have cyclophosphamide, okay, cyclosporin, whatever, levimazole. It is anti-helminthic, but it can modulate the immune system also. And the recent one, which is very important, okay, like rituximab. Okay, the next one. Yeah, prognosis in pediatric. What is the prognosis? You can read this to finish your presentation by this slide.
Okay, so prognosis for the nephrotic syndrome. So there is so if you guys read back at the slide for the classification, you can see the still resistant, the still responsive, the patient have infrequent relapsing nephrotic syndrome. So for nephrotic syndrome, so most children with steroid resistant nephrotic syndrome, they have repeated relapses. They have repeated relapse, and but these relapse will generally decrease in frequency as the child grows older. So in children, if they respond rapidly to the steroid and they have no relapse during the first 6 months after the diagnosis, so usually they will follow the infrequent relapsing course. So the relapse will be infrequent. So next, for the children with steroid responsive nephrotic syndrome, they are unlikely to develop chronic kidney disease, and this child will remain fertile in absence of the prolonged cyclophosphamide therapy. So, in nephrotic syndrome, to minimize the psychological effect of the condition and therapy, the children with idiopathic nephrotic syndrome, they should not be considered as a chronically ill person, and they should able to participate in all age appropriate childhood activities and maintain an unrestricted diet when they are in remission. For the children with steroid-resistant nephrotic syndrome, usually caused by the focal segmented glomerulosclerosis. They usually have poorer prognosis, and they can develop progressive renal insufficiency, which can lead to the end-stage renal disease, and they might require dialysis or kidney transplantation. So, in patient that have in a transplant recipient with focal segmented glomerulosclerosis, they usually have recurrent nephrotic syndrome. They usually develop recurrent nephrotic syndrome. So I think that's it.
Okay, thank you. Nice preparation. You need to add, all of you need to add your references and then send it to me. Let us now put our hand on the very important, the clinical sign here, which you have started with, is the edema. Okay, can you hear me or not?
Yes, I can hear you.
Yeah, so with edema, we must think by a mini mind map. What can be the cause of edema? We said it can be kidney, but kidney itself can be nephritic, can be nephrotic, can be chronic kidney disease, or like that. But beside that one, we must rule out any cardiac issue, any liver issue, any allergy, any autoimmune, even any malnutrition. Because malnutrition, like kwashiorkor in small children, can be presented by edema, and when you did protein, it may be low, but the criteria for diagnosis of nephrotic syndrome is not completed. That's why we have 4 criteria for diagnosing the nephrotic syndrome. So this is number one. What may be the other causes? The second point, which is very important, how severe is it? So how can we define the severity of the edema? So number one, we must go for the distribution. The most common is periorbital. And then we are going to look which other site which we must examine. So clinically, we must go for the, what is the second one? One amni.
Yes, doctor.
After I found the periorbital edema, so I must go to check another places which can get edema or swelling, which can be,
Either scrotum area,
okay, genitalia, okay,
abdomen,
abdomen. What is the name of this?
ascites.
Ascites, okay, abdominal ascites. How can we diagnose it? Important
But
must be
by
done.
performing the physical examination,
Yes, what is the name of the
uh,
test? Those ascites.
fluid shifting dullness or fluid trail.
Okay, it is very important. Then we speak, it can be abdomen, and remember that the genitalia is a part of the abdomen, can be genital soil. What else?
The leg or the pedal edema. You can look
Very
for
important.
the edema.
So what is the kind of edema in nephrotic syndrome?
What apa doctor? What is it?
Type of edema.
What type of edema?
Yes, is
Oh,
it beating
pitting edema.
edema? So I can also know how is the severity by start from down from the foot and going up until the knee, it may be more. So the level also will guide me. How is the severity and how is the extension? Okay, so I already started by the leg and by the abdomen and the genitalia, and in small children also we need to check the sacral for sacral edema, because usually he is remaining on back for a long time, so you'll find here. And don't forget at that moment the importance of examining the chest, because chest edema will be presented also by
Fluid effusion.
pleural effusion or pulmonary edema. Both of them, you need to auscultate for any crepitation or for any dullness. So it is very important to know what is the clinical symptom or sign in front of me, which is edema. From that, I will go to say what may be the cause. So I will rule out many causes. Now I came to conclusion it looks like kidney or nephrotic or like that. After that, I must check how severe is it. It is very important. Of course, vital signs are vital. Don't forget the vital signs. Maybe the patient very swollen, but he is getting shock due to intravascular fluid collapse. Okay? And at the time, even for the nephrotic itself, I must ask myself, yes, I did the test, I found the 4 criteria for nephrotic, I must go again and ask, is it primary or secondary? Because secondary are very important to rule out, which can be systemic, lupus, infection, malignancy, whatever. And at the same time, I must go through the complication, which we speak, the most common to be seen is the primary peritonitis, primary bacterial peritonitis, which is very common with other infection, okay? So it is very important to ask for the complication. At the end also, I need to ask about the complication of the treatment. Complication, Nabila, Nabila,
Yes, doctor.
what is the complication of steroid generally?
Infection.
Can precipitate infection, yes. But here it will not precipitate because it is treating the cause. Okay, what else?
Thrombosis.
A very common,
Thrombosis.
yes, a very common syndrome which happen if you are giving the patient steroid for a long time, known as.
Cushing-like features.
Yes. So you need to add one more slide about Cushing. Okay, it is very important. So you must know by that issue, if you put in your mind, in your concept, edema, what is the cause? What is the severity? I came to the diagnosis. What about the diagnosis itself? Is it primary? Is it secondary? And what is the complication? Even of the original treatment, if it is autoimmune, I may have another problem. If it is primary, I must suspect some problem. And even the management sometimes, like steroid, can cause Cushing. What about the other, like cyclosporin, can cause hemorrhagic cystitis? So we must know the story when we presented by one symptom. We can go at this. Another time we will see it may be nephritic or post-streptococcal glomerulonephritis. We will deal with another scenario. Okay, good. I hope now you understand our message, how to practice medicine, how to build yourself by a very broad differential diagnosis of anything. What can be the systemic cause? What be, even if in one organ, what can be the cause for the same disease? It can be primary or secondary. What is the complication? What is the indication for some important, which we spoke about, the kidney biopsy? And don't forget, as I informed you before, if you have chronic disease, you must touch the chronicity and the relapse of the disease and what is the treatment given at the moment. It may be there is the mother fed up and she has no compliance with medication. So you must take care. Okay? Thank you
Okay, doc.
for good preparation. Okay. If you don't have any questions, we can go for the second case as we need to close our session at 2, inshallah.
Doctor, I have a question.
Yes.
So, to determine the severity of this nephrotic syndrome is by looking at the severity of edema. Is it like that?
It is one of the major presentation
Mm.
of severity. Then you are going to check the urine dipstick. It will tell you how many severe is the proteinuria. Is it 4 plus, 3 plus? And then you are going to check the blood, how much is the severity of the albumin, hypoalbuminemia or hypercholesterolemia. So you are suspecting what is the treatment and what is the suspected complication. It is a series, but it must start by your clinical.
Okay.
If you are starting our practice depending or rely on investigation only, we will be very poor in our clinical sense. And sometimes you are away from some facilities or from some investigation which is not available or very costly. If you didn't rely on your clinical sense, it is very dangerous. And even clinical sense will help you to constrict the investigation. It is not wise to request now, if you are speaking about the causes of edema, to make investigation for nephrotic and nephritic and for cardiac and the liver, and it will not be like that. It will be my clinical sense will give me the top, as your colleague said, my professional diagnosis is that, and I will go through it Sometimes at the end, I found myself didn't pick the cake, so I will do another trip to go the second differential diagnosis or third. But we are not a doctor of open the investigation without rationale. If there is a rationale, of course, you must go.
Mm, okay.
Okay, please.
Yes.
We are starting now. We have about 1,000 day to practice medicine. If every day you are doing a job like that, you are together presenting this issue, you are giving it, with time you will find yourself have a 1,000 improvement in your clinical sense, in your achievement, inshallah. So you will be competent doctor, you will be honest doctor.
Okay. Thank you,
Okay.
Doctor.
Let's go for the coming. You have 45 minutes. Try to construct the history so we are able to do that. So the first one was Afik Azmi. Who is the second one?
Al Hakim and Umi for the
Oh,
second case.
okay. Go ahead, Hakim.
Okay. Okay. So today I'm going to I hope you hear me. Okay. So today we're going to do case presentation about neurology. Okay. So let's proceed first with the role play. Okay. Umi, are you ready?
Yes.
Okay. Alright. Assalamualaikum, madam. My name is Al Hakim, a third year medical student in pediatric posting, in charge of assisting you today.
Waalaikumsalam.
Okay. Is this your child? How old is he?
Yes, this is Amma. He's 1 year, 4 months old now.
Okay. What brings you here today?
My son had an episode of eating last night while he was sleeping. He was moving around, his hands and feet are moving repetitively. And there's also uprolling of the eyeballs.
Okay. Do you notice any drooling of saliva, smacking of lips, or biting of tongue?
No, I didn't notice those.
I see. Okay. How about any urinary or bowel incontinence?
None that I was aware of.
Okay. Then, what did you do during the fit?
I tried to call him, but he was unresponsive.
Okay. Do you remember how long it lasted?
It was around 5 minutes, and when it's over, he cried.
Okay. I see. So, after that, you brought him here, right?
Yes, that's
Okay.
correct.
Okay.
And then here it occurred again. The nurses and doctor noticed him having another episode of eating.
How about it? Is it similar to the first time?
Yes, it is similar, but this time he had drooling of saliva.
Okay. How about the duration?
If I'm not mistaken, it was around 3 minutes, and it ended spontaneously.
Oh, so the first one is 5 minutes and the second was 3 minutes. Okay. How about the fever? Does he have any fever?
Yes, he does. Yesterday, after following me and my husband from work at about 9 p.m., I noticed he had a fever. He was warm to touch.
Are there chills and rigors?
No, yes,
What about the temperature? Did you record his temperature?
yes, it was 38 degrees Celsius.
Okay. Did the fever go down at all?
No, it was continuous.
Okay. Did you give him anything to reduce the fever?
I gave him syrup paracetamol I bought over the counter, and I also did tepid sponging, but the fever was not relieved.
Okay, I see. Are there coughing and runny nose associated with the fever?
No, other than the fever, he's okay. He's active like usual.
All right. Okay. May I ask if there's any head trauma prior to the fitting?
No,
Okay. Is there any time you noticed that he couldn't tolerate being in bright places?
no,
Okay. Does he cry when you lay him down?
no. Except when he's with my husband, he likes to cling to my husband, so he doesn't want to be separated from him.
Oh, okay. Okay. I see. Is there any drowsiness or irritability?
No,
No. Okay. Any skin rashes?
no, there isn't.
Any shakiness?
No.
Okay, all right. Now I want to proceed with the another. Okay, does Amma have any known medical illness and any surgical history?
No, he doesn't have any of that.
Okay, is this his first hospitalization?
No, before this, he had been admitted to HTAA for 4 days due to pneumonia.
Okay, about the birth history, did he have a normal birth or does he have any complications?
He was born full term, but
Okay,
it's emergency cesarean section, and his weight is 3.9 kilogram. However, he appeared yellowish at the first 3 days of life, and he was admitted to an ICU for phototherapy.
okay. Next the development. Okay, how about his development? Is he able to walk?
Yes, he's able to walk, run, and also sit on the chair.
Okay, how about holding things?
Yes, he can hold a pen. He can also build a tower of 2 blocks.
Okay, does he able to say any words like mama or papa and even pointing at something?
Yes, he can say those. He can also say bye, and when he wants something, he pointed to it and say nah, like that.
Okay. Yeah, how is his social behavior or self-care right now?
Right now, he's able to feed himself using spoon and cup.
Okay. Is he breastfed till now?
Yes, he's breastfed until now.
Okay. Does he ever started weaning?
Yes, at the age of 4 months, he was given nestem and porridge.
Okay. What about his diet right now, currently?
Currently, he eats an adult diet 3 times per day with rice, chicken, fish, and also vegetables. And thankfully, he's not a picky eater.
Okay. Okay. Other than the syrup PCM that you give him, is there any drugs that you give to him?
No,
No. Okay. Does he have any drug allergy?
no, none that I was aware of.
Okay. Does your child follow the immunization program completely?
Yes, up to his age, he does follow the complete immunization program.
Okay, that's good. Okay, do you or your husband have any non-medical illness?
No, we don't.
Okay, does he have any siblings?
Yes, he has an older brother and an older sister. He's the youngest.
Okay, is there any similar illness in the family?
No, we are all well.
Okay, is there any history of epilepsy in the family?
No, there isn't.
Okay, okay, all right. So may I ask, what's you and your husband occupation?
We own a business in Teluk Cempedak.
Okay, may I ask again, do you or your husband smoke?
No, we don't.
Okay, I'm sorry, but I have to ask, do you or your husband drink alcohol?
No, we don't.
Is there any contact with travelers?
No.
No, okay, all right. Okay. Did you and your family travel anywhere or went to a river or water park in these past few days or weeks?
No, we didn't.
Okay, that's good. Okay. Is there anything else you would like to mention?
I think that is all.
Okay, thank you for your time. Later, I would like to do a physical examination on Amma to know more details about his condition. Okay.
Okay.
All right. Okay. So that's enough for the role play. So now I'm going to do the what was it? A summary of what the parents said to me. Okay. So the history was taken from mother. The child was apparently well until prior to admission when he was sleeping around in the morning. The mother noticed him started to develop an episode of repetitive jerky movement. She described it as repetitive extension and flexion of upper and lower limb and uprolling of the eyeballs during sleeping. The mother did not notice any drooling of saliva, smacking of lip, biting of tongue, and urinary or bowel incontinence. During the attack, he was unresponsive to his mother's call. The mother claimed the episode lasted around 5 minutes. She also stated that his child cried after the fitting. After the first episode of fitting, the mother decided to bring her child to the emergency department of HDAA. Upon admission to the ward around 5:30 a.m., he developed second episode of fitting. It was witnessed by the nurse and the doctor. The episode was similar as the first attack, where he had stiffening of both upper and lower limbs, up rolling of the eyeballs, and drooling of saliva. It lasted about 3 minutes and aborted spontaneously. Prior to the episode of fitting, the mother claimed that her child was developed fever in the evening, around 9 p.m. of the same day, when he was back from following his parent from work. He was warm to touch with chills and rigors. The recorded temperature was 38 degrees Celsius. The fever was continuous. It was not relieved by tepid sponging and syrup paracetamol over the counter. The fever was not associated with coughing and runny nose. Otherwise, he was active as usual and tolerating well. There was no history of head trauma prior to the episode, no sign of photophobia or neck stiffness, no irritability, no history of febrile fit or epilepsy in the family. There was also no history of sick contact, traveling history, or any related water activity. Okay, so now let's proceed with the slide. Okay, the chief complaint is Ama, 1 years old, 4 months, 1 year, 4 months old, Malay boy. Emergency Department of HDAA, fitting associated with fever on the day of admission. Okay, so this is the history. So, okay. Okay, now with the systemic review on the general inspection. In general, you can see that he had a fever, and of course, the head and neck has no sign of any significant. Okay, so the cardiovascular system was normal, respiratory was normal, gastrointestinal, the color stool was normal, without blood or pale colored stool, and other system was normal. Okay, so regarding the past medical history, this is the second admission. The first admission during June due to the rapid breathing and was treated as pneumonia. So the nutritional history was normal, birth history uneventful, and the mother did not have a gestational diabetes mellitus pregnancy, induced hypertension, or intrauterine infection. Okay, so the developmental history, the patient had normal development milestone and the age is appropriate with his age. Okay, so the immunization history, the mom followed completely up till his age. Okay, so the drug history that the mom told us that he was given syrup paracetamol over the counter, and so and he's no drug allergy. For the family history, his father and mother has no non-medical illness. He is the youngest sibling out of 3 siblings. He had elder sisters and brother age of 8 and 7 years old. And other family members were normal and healthy. There was no history of epilepsy, asthma, congenital anomaly, neurological disorder, or similar illness in the family. Okay, for the social history, they live together with his parents at Bukit Stongkol, and the house is well equipped. Um, and the total house income is 2,000 monthly. Both of his parents are non-smoker and did not drink alcohol and have no high risk behavior. Okay, so next is the physical examination. So during the general examination, the positive findings is the tonsil showed redness and inflamed with grade 2 with no exudate. There was a granular intake at his left brachial without any infection. And the others, it was a negative finding. So next is the vital sign. Blood pressure is 95/53. Heart rate is 143, normal. The respiratory rate 28. And the temperature was high, which is the patient is febrile, and the oxygen saturation is normal. While the patient weight is 9.2, while the height is 77 centimeters, and height circumference is 47 centimeters. No significant findings. Okay, so the other systemic examination like central nervous system, the child was conscious, alert, and active. So there's no significant findings. We proceed the respiratory examination. It it was the was all normal, no any abnormalities, and the cardiovascular also normal. With the abdominal examination, there was no surgical scar, dilated vein, visible pulsation, or abnormal peristalsis movement. So no scrotal or edema noted. Okay, so there's no other positive finding. and next is the musculoskeletal examination. Okay,
Wait,
so
wait.
yes,
Where is the nervous system?
huh?
Where is the neurological examination?
Where the neurological examination? This this one.
Okay, so
Okay,
no fasciculation power, Babinetsky, Brodzensky. What is missing here?
it's missing.
Yes.
Uh,
We're examining CNS for a patient who has convulsion.
for the patient that has convulsion.
What is in your differential diagnosis?
My differential diagnosis:
Yes.
complex febrile seizure due to the acute tonsillitis.
Yes.
Yes. Uh-huh.
What other cause?
Excuse me. What are the cause?
Payroll, yes.
Mm, what,
This is an important lesson. If you have some signs, we must know that there is some important disease or some important differential diagnosis urgently must be ruled out.
Oh, okay, okay. So,
Who can,
huh?
who can answer?
Is it the Kernick-Ambrosinski sign?
Yes.
Oh, but
Yes.
that one is negative.
Yes. You cannot rule out meningitis without specifying that meningeal irritation signs, which is Kernick's and Brodzensky, and the neck stiffness are negative. Good to do all this neurological examination, okay? And then small baby, it's very important to comment on the anterior fontanelle, because in small baby in the first year of life, or maybe slightly more, you will not detect Kernick's and Brzezinski. You will detect the bulging or tense anterior fontanelle. Am I clear? Okay, continue.
Right. Okay. So musculoskeletal examination, there's no findings, no positive. Okay, here's the differential diagnosis. My provisional diagnosis is the complex fever seizure, secondary to acute pharyngitis. So for the points is high fever, 2 attacks of fitting in one episode, injected grade 2 tonsil, as we see during the general examination. Okay, here's the differential diagnosis. Is the meningitis. So the point against is the no drowsiness, confusion, or irritability, and the Brzezinski and Koenig sign is negative. For encephalitis, there is no history contact with travelers and no skin rashes. For epilepsy, provoking factor, fever. Okay, so no family history, no evidence of intracranial pathology. And hypoglycemia, there's no shakiness, no irritability, or no hunger sensation. Okay,
Wait a while, very
right.
good. Uh, I think our colleagues in internal medicine make a nice book known as The Art of Differential Diagnosis. Okay. Uh, Here is the point which I insist for every patient to comment about the diagnosis and the differential diagnosis is that we cannot rule out meningitis until we did. It is written by you, yeah, Kernigs and Brodzensky, and even neck stiffness, okay, and the bulging anterior fontanelle.
Yeah. Right.
For lights, it is very important because many of you cannot differentiate between meningitis and encephalitis. You didn't add enough knowledge here. You said no history of contact with travel because a lot of viruses which can cause that one. No skin rash. Skin rash can still occur with bacterial, but he may no herpes simplex rash like that. But the most important for encephalitis to differentiate from meningitis is the behavioral changes. He cannot open his eye, he has photophobia, he has some behavioral changes, which can denote that we have either meningitis or encephalitis, or sometimes we have meningoencephalitis. Okay, so you need to correct some points for this meningitis, for this encephalitis, for the epilepsy, which is very important. You must write here recurrent unprovoked seizure. Okay, and it must be recurrent. We cannot diagnose from one unless you became a top in subspecialty and you have to judge that. Okay, hypoglycemia and other metabolic diseases, because not hypoglycemia alone, many can cause convulsion, even hypomagnesemia, hypocalcemia, all this. So hypoglycemia and other electrolyte and metabolic disease. You must take care that many cases of end organ failure, like severe hypertension, can cause convulsion. Many cases of post-streptococcal glomerulonephritis will be presented by convulsion secondary to hypertensive encephalopathy. So you must write it here also, because it is common.
Right.
We used to see many patients with hypertensive encephalopathy. He came with convulsion, and we found the blood pressure, and then when it come to the urine, we found this cola color urine, and we can come to the final diagnosis. Okay?
Okay.
Okay. Continue.
So we proceed with the investigation by Umi. Okay, Umi.
Okay.
Okay. Assalamualaikum. I will proceed with the investigation. Next. So for the investigation, first we need to know what's the cause of the fever. So we have to do full blood count to see if it's caused by infection, and also to do blood culture and sensitivity to look for the infective agent, and urine analysis if we suspect urinary tract infection, if the patient comes with smelly or frothy urine. For the random blood glucose, uh, we have to do it to look for hypoglycemia, as it can be one of the cause of seizure, and also serum electrolytes, in which metabolic disturbance is also one of the cause of seizure. For the lumbar puncture, it is indicated in patients with clinical features that suggest a possible meningitis or intracranial infection. They may come with vomiting, neck stiffness, and also photophobia. For the and also it is indicated for infants between 6 to 12 months if the immunization status for HIV or Streptococcus pneumoniae is deficient or undetermined due to high risk of infection. Next. For the neuroimaging, we can do CT scan or MRI. Neuroimaging should be done in children with abnormally large head, persistently abnormal neurologic examination, and also signs and symptoms of increased intracranial pressure. For the EEG, it should be done in children with prolonged seizure and also recurrent febrile seizure with developmental delay. Next. For the management, next. Okay, it can be divided into pharmacological and non-pharmacological. For the pharmacological, for the control of seizures, we can give benzodiazepines, in which we can give oral or rectal diazepam, but this is we can give it to patients with prolonged seizures. For the control of seizure, we give paracetamol or ibuprofen, and also antibiotics for the infection. For the non-pharmacological, we have to control the fever by temperature monitoring, and also tepid sponging of the whole body, and also cool liquids to drink to lower the temperature and also for the hydration of the child. We should also monitor the side effects of diazepam, in which it may cause imbalance, lethargy, and also irritability. Next. There's also questions, but I will answer myself. Next. Okay, so this is a case of an ambulance brings 1 year, 3 months old boy to the emergency department with a seizure associated with a sudden onset of fever with temperature of about 38.3 degrees Celsius. The mother noticed shaking of the arms and legs, and his eyes had a blank stare. This went on for about 5 minutes. She called 911 and the ambulance was dispatched. The boy was given antibiotics and antibiotics, and the condition improved without any recurrence. So next, okay, so boleh, next lah, next, next, next. Okay, so what's the definition of febrile seizure? It is seizure occurring in association with fever more than 38 degrees Celsius in children aged 3 months to 6 years with no evidence of intracranial pathology. How is febrile seizure classified? So it can be classified into two, which are simple and also complex. For the simple one, it is less than 15 minutes and there's no recurrence in 24 hours. As for the complex, it is more than 15 minutes with multiple seizures in 24 hours. So number three is what is the type of febrile seizure in the case above? Can you go back?
Excuse
Next.
me? How? Next,
Back,
okay.
back, back.
Oh,
Like
back.
many times. Many times. Okay, oh no. No. No, to the question, please.
Oh,
Okay, so what's the type of febrile seizure in the case above? So it stated that it went on about 5 minutes only, and there's no recurrence. Thus, this is simple febrile seizure. Next, please. Okay, so state two complications of febrile seizure. It can cause epilepsy and also recurrence. Next. So for question two, an 8 months old girl came to emergency department with a complaint of sudden loss of consciousness and seizure activity. Her parents report 4 days of fever and 1 day of vomiting. The mother also noticed her crying when she lays her down. Okay, next. So what are the etiologies of seizure? There are a lot of etiologies of seizure, which include infection, trauma, metabolic conditions, and also others that are caused by poisons, toxins, drugs, and also hypoxic ischemic insult. Next. So for the possible etiology, uh, mm, please go back to the question. Okay, so the question, let's see what's the possible etiology. So the parents note that the child has fever and also vomiting. And mother also noticed her crying when she lays her down, meaning the baby cries because it hurts. The neck is stiff. So since she's a baby, she can't really tell if it's hurt, so she just cries. So the possible etiology is meningitis. Next. So what parents should do during an episode of seizure? So first is they have to stay calm and do not panic. They have to take note of the onset and duration of the seizure, and also to remove dangerous objects around the child, and also to clear the airway, wipe away any vomitus or secretion from the mouth, and do not insert anything into the mouth. They should also not give any fluids or drugs orally, and also to lay the child on the lateral side. They should also stay near the child until the convulsion is over and comfort the child if he's recovering, and tap it sponging and remove the clothes to lower the temperature. And if there is a second attack, they have to go to the hospital. Next. So this is the last question. So it is a case of 5-year-old boy presented to A&E after having a generalized tonic-clonic seizure lasting 8 minutes. The seizure was self-resolving and he was drowsy afterwards. He had previously experienced a febrile seizure at 15 months of age. Next. What are the risk factors of the recurrent seizure? It includes younger age at onset of first seizure, first degree consanguinity of the parents, epilepsy in the first degree relative, and complex initial febrile seizure. Next is explain the procedure of EEG. Next, it includes the preparation, procedure, and after the EEG. So what should be prepared? The patient should not drink or eat anything with caffeine for 8 hours before the test because it can alter the brain activity. They should also refer to doctor about how much to sleep the night before if he is expected to sleep during the test. Next is to eat normally and the night before and the day of the procedure to avoid hypoglycemia. And also, they have to tell the doctor about any medications they are taking. And lastly is to wash their hair the night before the test. And they should also, on the day of the test, they shouldn't be wearing they shouldn't be applying any conditioning or styling products on their hair. Next is for the procedure. The patient will lie down on the exam table or bed, and then the technician will put 20 electrodes on the scalp, and then they will be asked to relax the eyes, uh, relax with eyes open first, and then with them closed. And then the technician will ask the patient to breathe deeply and rapidly, or to stare at the flashing lights, as this can change the brainwave patterns. And also, the electrode will pick up the electrical activity from the neurons and send them to the machine to be displayed. Next is after the EEG, then the technician will take off the electrodes and wash the glue and okay. And then the patient will usually will resume taking the medication they are stopped specifically for the test, and the recording will be sent to the neurologist. And that is all from me.
Okay, so now let us make it like a clinical sense again. If I have any child with convulsion, so what is the idea will come to my brain? Is if
Oh, conversion.
yes, you are
Um,
now graduated and you are in emergency department and the ambulance bring for you one child who is fitting.
um, to check if it's febrile.
Okay, so I will speak, is it febrile or afebrile seizure? Is there any clinical difference?
To know what's the cause of the seizure.
Yes. This is number one. Number two, what is the type of seizure? Because you didn't touch it during your presentation. How many types of seizure? We have focal, we have generalized, we have focal and then generalized, we have tonic, we have tonic-clonic, we have atonic. So type of seizure must be added to your presentation, even soft touch. And please, for both of you, Afik and Hakim, we need with the OSCE, we need many pictures, photos, child with meningitis, while we are doing the Kernig's and the Brodzinski, the non-blanching rash. For the nephrotic, we need to see how picture of edema in the face, on the leg, distended abdomen, kidney biopsy. All these are very important to see photos, please. Okay, besides the question, which may be very good, but we need the photos because we are deprivated from going to the hospital now. So the most important to speak about, is it focal or generalized? Because if you have focal seizure, it may be very dangerous. Okay, and then as your colleague said, is it febrile or afebrile? Then we are going to consider the duration of seizure. The duration. So one أمني,
Yes, doctor.
is the duration of seizure important to us?
Uh, yes, it is important because we can classify is it simple or complex. When it is simple, it lasts only less than 5 minutes, but it is classified as complex if it lasts more than 5 minutes.
Okay, so now we can come to the conclusion how to differentiate between simple or complex. I will ask another colleague, but what, yeah, this is the timing of the seizure now. It can guide me, is it simple or complex? What else is very important for the timing?
For the recurrence, is it recur in 24 hours or not?
Yeah, now we are speaking still between simple and complex, but did you hear about something known as status epilepticus?
Oh, yes. That one, if the seizure lasts than 5 minutes and it is emergency, right? Usually tonic clonic.
Not
Is it less than 30 minutes, Doctor?
yes. So the
Oh,
definition of
30 minutes.
status epilepticus, you must know it. What is the definition? Is either the child has got more than 30 minutes, or you must come to your references, or he has got another, yani he got one attack and he got the second, and between them he didn't regain consciousness. Because we don't know, it may be there is convulsion by electric, can be detected by electric, but we cannot detect it by our eyes. So you must know the definition of status epilepticus, because the status epilepticus consider emergency and you must intervene. Even as Nadira said, if the patient even starting for 5 minutes, we are going to start by the anticonvulsant. We are not wait until he became 30, because some people read that status epilepticus means 30 minutes and the family are under severe tension and the doctor are very quiet. Okay, it's convulsion now for 10 minutes. After 20 minutes, we will see. We'll see what's it. So even we must start our intervention if more than 5 minutes. It is very important. Okay, this is an important test for us. Number one, febrile or afebrile, because it may be epilepsy, it can be metabolic, or it can be infection. Second one, is it focal or generalized? Focal, we must suspect it can be insult to the brain, which is very dangerous. It can be hemorrhage, it can be brain edema, it can be malignancy, it can be vascular, it can be anything. So it is very important, if you found the focal one, you are putting a flag sign like your friend speak before, you are considered brain imaging, and you must try to know what is the difference between CT and the MRI, which is the best for every situation. We know that MRI is higher, but CT is still working and can give us a lot of knowledge. So you must know how to choose and what is the benefit of everyone, which one of the indication is the focal one. We must add also, beside that, the importance of skin examination in case of convulsion, because many infection like pneumococcal will be presented by type of rash which is non-blanching. You have like small bichicky and they try to press, it will not disappear. Non-blanching rash are very, very dangerous and it can denote severe, even life-threatening infection. Okay, so this is number 3, which is very important. You have in your pediatric protocol, which is a very nice, really book, which make a good collection for you. What is the management general lines? Okay, and even you must know the importance of EEG to diagnosing the epilepsy. But epilepsy initially is a clinical diagnosis. It is not a EEG business. Okay, am I clear? So you must know the simple and the complex one. The most important is to do like video if you are able, so you can see what is the sequence of the event. If the patient has sensation that he is going to get convulsion, it is very dangerous. It can denote some diseases. Okay, if it start focal or focal then generalized. If all this, what is the story before convulsion, then during convulsion, then after convulsion. You must ask. The child said, I was apprehending aura. Very important. What convulsion? Or how? What about his arching back? Comment after the convulsion itself. What happened for the child? He got like towards the paralysis paralysis with and we can give information the important that will of meningitis can be infected. We can give we can, okay, which you can give in but you have very small insulin needle rectally. Sometimes the baby you can we have something like rectal. We have one of the antiepileptics. It can be used IN, but it is not commonly used. So it is very important. And what is the investigation do you need to correct? And what is the bedside test test you need to do for any patient who has convulsion? What is the most test? The blood test. Who can answer?
Sorry, doctor, we can't really hear you. Hello?
If you got any patient with convulsion, it's important bedside tests. Important bedside tests for convulsion is broad. Again, important bedside tests for the convulsion is the dextrose. Can you hear me?
Yes, doctor.
So remember that if any patient is in critical situation, we are doing ABC. What is ABC? Airway,
Breathing saturation.
breathing, and circulation. ABC to do the D. Those has hypoglycemia, the treatment not valuable. So it is very important. It may we must do disclosure. I mean, I must examine the child if has any abnormalities. Like if he got signs, if he got barbaric rash, which you speak about before, which mean infection, if he got herpes simplex rash, all this will guide us to the diagnosis. Okay, so we have dextrose, we have disclosure, we must look for disability. I mean, if the patient got like hemiplegia after this convulsion and prolonged more than short time, or the patient has TODS paralysis, which is prolonged, or this abnormal. So remember that for any case of convulsion, we have A, B, C, 3D, which is the dextrose, disability, and disclosure. Okay, do you have any question? Do you have any question or not?
Not at the moment, doctor.
Okay, so please you need to complete your slides and put the pictures, and don't forget to put the Cushing, and try not to forget to put the point which you speak about convulsion. Okay, and you need to send it to me, the other point. I'm going to give a fake 7.5 with the same for Hakim.
All right.
This
Okay.
is your
Thank you,
marking
doctor.
now. Okay. I hope inshallah next time if you are doing a better job, I can give you more better. Alhamdulillah, today we are dealing with a very too important symptom, which is that the child became edematous, or the child have abnormal convulsive movements. That's good. Inshallah, hoping the next time you are choosing different one with different presentation, and see you inshallah soon. Assalamu alaikum wa rahmatullahi wa barakatuh.
Waalaikumsalam. Thank you, Doctor.
Thank you so much, Doctor.
Doctor.
Thank you, doctor.
Thank you, doctor.
Thank you, doctor.
You are welcome. نفع الله بكم